So, Oldboy, what do you got here?
You can start with like alcohol use disorder. Like the beginning of the movie, he's a drunk, and he's like, disruptive in the police station. I watched the Korean version. That's okay.
That's all I will discuss.
Okay. Yeah, he's like drunkenly calling his daughter from a payphone.
So, alcohol use disorder. So, a couple of quick comments on this. Number one, you should at least appreciate that prior to 2013, there were two diagnoses, which was merged by the American Psychiatric Association into a single diagnosis of alcohol use disorder, previously known as alcohol dependence and alcohol abuse. For alcohol dependence, you needed 3 criteria. For alcohol abuse, you needed a single criteria. In 2013, you combined the two. Basically, you have a comprehensive list now. There was a small tweak, but not that significant, where craving is actually in, and legal infractions was removed. So just one quick switch. Otherwise, it's the combined list for which you need 2 criteria. So that's alcohol use disorder. And those criteria are applicable to any substance use. So stimulant use disorder, heroin use disorder, etc., same exact thing. All right. For purposes of your education, please check out our YouTube video on teaching those diagnostic criteria through the cartoon, Clippity Clop. Easy to remember if you go through that, it really is. And in as much as it's a cartoon, experiencing that when you go into your future career, even if it's non-psychiatric, or especially if it's non-psychiatry, you'll remember it. Other than that, there are induction syndromes you have to be concerned about too, for any substance, including alcohol. I think the first 3 are relatively straightforward, at least the first 2 are. Intoxication, you should never miss alcohol intoxication on the shelf exam. I mean, just from your own personal experience, I don't mean to offend anyone, but you cannot possibly miss alcohol intoxication, which is why the board is not likely to test you on it. Alcohol withdrawal is something different. Alcohol withdrawal, you should be able to identify on a shelf exam. You will see it. And that includes the severe withdrawal states, which are hallmarked by either seizure or perceptual disturbances. For those complicated withdrawal syndromes that are hallmarked by perceptual disturbances, there are 2 types. What are they?
Delirium tremens and acute alcoholic withdrawal, alcoholic hallucinosis.
So, how do you tell the difference between the 2?
Time frame for last drink.
Probably not. They're usually, they'll occur around hospital day number 3, pathognomonic on your shelf exam. There's another way you need to differentiate these 2 conditions. Again, this is alcohol withdrawal delirium and alcoholic hallucinosis.
I think is a hallucinosis, like if you ask them, are you seeing things, they see things, but they know that it's not real, but in delirium tremens, they can't tell.
That's it. Right? The sensorium, they're being disoriented, their confusion will hallmark delirium, hence alcohol withdrawal delirium, otherwise or formerly known as the DTs. Individuals will usually have an intact sensorium. They'll be awake, they'll be alert, they'll be oriented to person, place, and time. They'll have intact speech, but they will tell you that there are snakes crawling out of the wall or there are spiders crawling over you. Right? So perceptual disturbances will persist. Number 3, in terms of the induction syndromes or the alcohol-induced mental disorders. I'm not going to review them today. They're best reviewed in the context of a chief complaint for which you think there's a mental disorder that will, what's the word I'm looking for? There's a mental disorder that explains the patient's chief complaint, so depression, anxiety, psychosis. As you think, well, this might be depression, this might be an anxiety disorder, this might be schizophrenia, you must always first rule out the direct and physiologic effect of a substance. So that's where that comes in. Right? So much easier to learn from that context. That is the context of looking up a mental disorder. And then there's a 4th category of induction syndrome, which is a potpourri, that is other. And the Wernicke's-Korsakoff syndrome fits there. Fetal alcohol syndrome fits there. Right? So That's a very quick primer on alcohol as certainly introduced through Oldboy. Do any of these actually, are any of these developed in the narrative of Oldboy?
Yeah. There's a scene in the beginning where you see like ants crawling out of, or like bugs crawling out of, he has a formation.
Okay? And this is in the beginning of the movie.
Yeah.
Then there is reason to suggest that the entire rest of the movie may be a product of his own mind.
It's possible.
That's what I was feeling from the start.
So, alcoholic hallucinosis. Likely, in as much as he's able to articulate what's going on, he seems oriented. So maybe not alcoholic delirium, but this is a case of alcoholic hallucinosis after all. Interesting. All right. So this is when you'd have to rewatch the film with that in mind to see if in fact there are inconsistencies that make the clinician have to defend what's going on, or certainly the opposite, the antithesis, which is parts of this narrative that support the working diagnosis that Oldboy is a fictional case study of alcoholic hallucinosis and its main character. Okay, I'll buy it. Any other thoughts?
If we were to assume that the things that were happening in the movie were actually happening, and like being gassed, captured, imprisoned for 15 years, that could also induce a state where he's, he's delirious to the point of having hallucinations. He's, not receiving an appropriate diet of any. He's eating the same non-nutritional foods every day. He has no interaction with anyone outside the prison setting really. So that could be like our differential there, that these are unrelated to the alcohol use possibly going forward.
So maybe this is in fact a delirium,
Right.
where the articulate nature of his speech and the comprehension is not really true, but otherwise a product of his own delirious mind.
Right.
And that's what we're seeing. Brought upon, so it's basically there's perceptual disturbances and there is a change in mental status.
Yeah.
But the timing of it's going to be different. That is, we don't think it's incident to alcohol withdrawal. We think it's incident to what comes after, which probably is going to be mediated by hyponatremia and malnutrition. Maybe even hypernatremia, depending on how much free water he's ingesting. So I think a routine delirium workup would uncover either, but maybe this is a case study of delirium. By the way, just as an aside, Stephen King's Misery was formulated as a similar case, where Paul Sheldon, once he is captured, undergoes alcohol withdrawal delirium. And there's evidence to support that. Certainly, at least one medical student made a really good case of that in terms of what that was. So watching these two movies back to back might be interesting. Other thoughts?
I guess something else, like going off of those lines, you could think of related to alcohol use could be some sort of like Wernicke encephalopathy or Korsakoff syndrome, because it was sort of a rambling, confabulatory story to start with. Like it was kind of, a wild turn of events that I feel like someone who was presenting with that symptom could, come up with, or something else you could think of given his history of alcohol use.
Yeah, so if there's confabulation, what the clinician is deducing then is that there's amnesia. Mm-hmm. And then you think that maybe the amnesia, especially given his alcohol history, is mediated by thiamine deficiency. Putting words in your mouth. But that's basically what you just said. Mm-hmm. So that's, and I would guess that again, if part of the story is true, his being in prison, I'm not sure they're going to give thiamine supplements there. So I'm not seeing, so the malnutrition may be then a perpetuating factor. All right? Wernicke's-Korsakoff. Again, Wernicke's is the acute syndrome. Again, it's an alcohol induction syndrome or an alcohol-induced syndrome that is not intoxication, it's not withdrawal, and it's not a mental disorder, it's other. And it's hallmarked by a triad of, I was going to actually try to go in order. You're right, though. Ataxia is right. It's confusion, ophthalmoplegia, and ataxia. Thiamine deficiency is the cause. It spells coat. Right? Confusion, ophthalmoplegia, ataxia, thiamine as the cause. So thiamine deficiency as the cause. It's coat. If left untreated, it could then evolve to RACK, R-A-C-K. Retrograde amnesia, impaired amnesia, and because of that, confabulation. And then the K is Korsakoff psychosis. So CORAC is the continuum. Right. So if you're asked, what cranial nerve with regard to the ophthalmoplegia and why? And this is where in cats, if you're asked, and even if you're not, you say that psychiatry, the psychiatry clerkship, does continue to provide basic science with regard to its education because Dean Perugino says it must. This is it right here. Just redirecting you. Just to make sure you get proper, don't mention my name, just say it as it does. It's cranial nerve 6. How come? Why cranial nerve 6? It is the longest and therefore the most susceptible to toxic metabolic damage. All right, so cranial nerve 6. All right, anything else here?
What about the person that kidnapped, or the person that like did it all? I forget his name. The mastermind and like his own trauma slash.
Yeah, sure.
Or, oh wait, no, this is the old one. Sorry. Or yeah, him.
I mean,
Like, what about?
his motivation, you mean, like, for
His
the...
motivation and also. So I'm getting like the old one and the new one. There's probably weird different motives. The old one is a little bit.
The old one
sound.
The sister.
Yeah.
His sister suicide. That's his motive.
It sounds like, I mean, we touched on this morning, but I would suggest that a sexual deviancy
Right, yeah.
is the core to the character's mental health issues.
Yeah.
And remind me if I'm wrong, because I hadn't seen this recently. He was being bullied by other children who didn't necessarily know that he did what he did, but in saying and bullying him the way they were, they definitely hit on something that was true, nonetheless. And of course, the child who was being bullied doesn't necessarily grasp that. That is, oh, they're just saying it to be mean. They would never know, just a coincidence. He of course takes it much differently, as you would expect. A little, I mean, again, it's egocentrism, and not being able to step outside of yourself and recognize as perhaps a third person perspective. Sheer coincidence, nothing to get worked up over. But again, something that you would consider to be normal. Normal egocentrism there. We mentioned this morning that we're going to talk about them. We may as well review them right now. Not gender identity disorder or gender dysphoria as it is diagnostically labeled since 2013. Not a sexual dysfunction, but a sexual deviancy. So that's that third and final chapter that we addressed this morning. Can somebody name me the list of sexual deviancies, otherwise known as the paraphilias? We haven't talked about this, right? We have talked about this, right?
Is transvesticism one of them?
Transvestic fetish is, right? And just for completeness sake, another change in 2013 with the publication of DSM-5, all of these names really have the word disorder put on the end, because it's one thing to say you have a deviant behavior, which simply means that you're behaving in a way that is not culturally sanctioned. But if it's not causing clinically significant distress or impairment, there's nothing to do from a psychiatrist's perspective. So we separate out a fetish, for example, from a fetishistic disorder. Those are two different things now. So I just gave one away, another one is fetish. So there's transvestic fetish, and there's fetish. There's more.
So it's transvestic fetish disorder?
Right.
Okay.
Right. It's probably got a couple of syllables in there, fetishistic disorder. Don't worry about it. For us, when we say fetish today, when we say transvestic fetish, I'll assume you mean the disorder, right? Because that's what a psychiatrist will focus on. So that's gonna, I just want to get that opening statement out, so then we could just call it and use the least amount of syllables as possible. How did you learn the planets?
My mother, my very,
Yeah, it can't be my mother.
my very, so my very elegant,
Eager.
Eager, oh, it's like eager, elegant.
His mother just served us
Just served us.
nachos or 9 pizzas.
Yeah, but
Well, we'll stick with Pluto for now. All right, so if that's the case, what about your very elegant father? Nobody ever talks about that here. So what about your very elegant or eager father? My very eager father serves porn for thrills. And now you have all the sexual deviancies. That's the easy way to learn the paraphilias. My very eager father serves porn for thrills. Right? M, masochism. V, voyeurism. E, exhibitionism. F, frauderism. S, sadism. P, pedophilia. F, fetish. And T is transvestic fetish. Going in order again, M, masochism. For these deviant behaviors, the objective must be for sexual gratification. If you're doing the same exact behavior for any other reason other than sexual gratification or achieving sexual gratification, it is not considered to be sexual in nature. It's not considered to be a sexual deviancy. Right? So that must be the motivation. What is the person doing for sexual gratification with regard to masochism, aka masochistic disorder?
hurting someone.
Yeah. Right. Deriving pleasure from one another's pain, humiliation, or subjugation. V, very.
Oh, I apologize for interrupting. But I know pyromaniacs, like that's there's a factor of like sexual arousal with lighting fires. Like, so is that just like one of these paraphilias adjacent?
So the answer is yes, if in fact that's the motivation for fire setting. And pyromania, the motivation will be to quench an impulse that the patient will often describe as coming out of the blue. So, doc, I couldn't stop it, I just had this impulse to fire set. If that impulse is subordinate to getting sexual gratification, then we're not talking about pyromania. We're talking about paraphilia NOS, not otherwise specified. Right? And quite frankly, a person can get off on any object and anything. So there's no way the American Psychiatric Association can publish or label every single object of sexual gratification. The chapter would literally be stacked to the ceiling. So, I mean, you've got your more common ones. They're published, they're diagnostically labeled, but everything else goes into a grab bag of not otherwise specified, including fire setting. V, voyeurism, voyeuristic disorder is, what's the focus? Pardon the pun?
Like watching someone else do something.
Right? Watching someone else either engage in sex or disrobe. Father, F, frauderism, frauderistic disorder.
Oh, it's rubbing up against someone who doesn't know that you're rubbing up against them.
Exactly right. Well, they know you're rubbing up against them, but they're not consenting. They may or may not know. I take it back. I take that back. Very, very concerning study of people who have ridden the local subway and the extent to which they've been violated. I mean, the point incidence is just would blow your mind. We'll leave it off the report, but it's high. It's very high. The incidence of these disorders are horrifically underrepresented in the literature. Sadism.
For oneself. Oh, yeah, inside of this.
Inflicting pain or humiliating others. Good. Pedophilia. engaging in sexual acts with a prepubescent person, whether they're consenting or not. Fetish.
Like an obsession that's,
Like a bizarre obsession.
yeah, that's unrelated to sex, that is sexually arousing.
That's related to sex, all right,
Yeah.
but it's sex with an inanimate object or specific body part. The sexual object cannot be a vibrator. If a vibrator is normal. By the way, don't laugh, the psychiatry invented the vibrator.
Really?
Yeah.
Isn't that sensory hysteria?
I'm sure that psychiatrist is pissed off they didn't patent that.
Yeah,
It was the tree hysteria, exactly right. I think the movie was called Hysteria, if I recall correctly. It's a good movie. All right, and then if the focus of the sexual gratification is cross-dressing, then it's transvestic fetish. It was so common that they pulled it out of the general definition of fetish and created its own diagnostic category or diagnosis. Right, transvestic fetish. People can cross-dress for 1,000,001 reasons, but if it's for sexual gratification, then you diagnose. Right, so those are your paraphilias. So in our movie, back to Oldboy, we probably are struggling with a diagnosis of either pedophilia or a paraphilia not otherwise specified. Incest, again, is not, or does not carry a diagnostic label in the DSM. But definitely a paraphilia. Other thoughts?
So would that be paraphilia NOS if it's incest? Okay.
And what if it's acceptable amongst the culture? Does it not become?
It becomes a much more interesting conversation.
Like Game of Thrones.
I know, I get it. No, I get it. There's nothing to do here. If it's part of if it's culturally sanctioned, there's nothing to do here.
There's no free.
Yeah, I mean, the sticky area is what if it's culturally sanctioned in one culture and the individual moves to a culture in which it is not. I think the way to finesse that would be for a psychiatrist to say that there's nothing to do here and leave it up to law enforcement. The psychiatrist isn't saying it isn't a crime. It's just that you appreciate and respect the culture from which it comes. Unconditional positive regard. And I would think in a very carefully worded formulation, conclude that there's nothing further to do. But again, I have to say that law enforcement is probably going to say otherwise. And there's just two different opinions. Anything else with Oldboy?
There's references to suicide. Both has a history with the sister and then the mastermind character threatening to use it as a tool to prevent like the main character from being able to exact his revenge, basically. I guess like thinking about that, one way is like a traumatic event from his past, and then he also is using it as kind of a tool to manipulate the people around him, kind of just like as an act to take. Like I'm thinking about like with patients referencing suicide as something where they know it enacts a sort of response from the medical team, and then when you interview them, they say, "I just said that to." You know.
And you said that because.
Right, I only said that because, yeah, so.
Now, the question I have is, with regard to, I only said that because, was that something premeditated, or was that something that was more impulsive,
Right, yeah.
but now is reflected back on, I only said it because? Do we have any feeling there? Because if we get one versus the other, there are two other diagnoses to consider. What do we call it when an individual misrepresents themselves for reasons and motivation that they are unaware of because it is subconsciously motivated.
Acting out.
Fictitious disorder?
So the question I have here is there a fictitious component to this individual's behavior? On the other hand, if there's evidence to suggest that this was all premeditated, that is, the individual misrepresented, in this case himself, due to reasons that he was absolutely aware of, then we're thinking that this may be malingering. So we're applying those medical terms to perhaps non-medical issues in the film, but there's a parallel here, and the extent to which a psychiatrist would offer an opinion, I think we need to tease out. But it does bring up issues pertaining to factitious versus malingering. And just remembering, at least in our context, that the motivation will help differentiate, because in both conditions, the patient is lying to your face. Not necessarily in the film per se, but certainly in the medical field, there's a third option in which the patient is misrepresenting themselves, but doesn't know that they are. That is, they actually believe that their chief complaint is true. Doc, I can't move my left arm, because they can't. But the underlying medical and neurological workup show no physiologic evidence as to why they have hemiplegia. What's that? Louder? Yeah, so that would be a somatic symptom or related disorder. If it has to deal with voluntary motor and sensory function, as the example did, we'll call it conversion. If it deals with anything other than that, we call it somatic symptom disorder. So in that way, conversion disorder is one example of a type of somatic symptom disorder where the deficit is in voluntary motor or sensory function. If it deals with anything else, headache, other neurological complaints, pain, we're going to call it somatic symptom disorder. So again, conversion in that context is a specific type of somatic symptom disorder. So somatic symptom / related disorder, factitious disorder, malingering. All right, there's your continuum.
What about illness, anxiety?
Illness anxiety disorder is another disorder related to somatic symptom disorder, but it's different enough where ultimately, I guess, my guess is that the DSM is going to move it to a different chapter. And it'll likely be part of the anxiety spectrum disorders down the road, maybe as quickly as the DSM 6. But right now, what was formerly known as hypochondriasis, which, by the way, is the focus of attention in the movie called Hysteria, that we spoke about before, referenced before. You have a preoccupation with having or acquiring a serious illness. That's much different than presenting with a chief complaint. So it's related to the somatic symptom disorder, but ultimately, I think it differentiates enough where it's probably best formulated within the context of an anxiety spectrum, hence illness anxiety disorder. Preoccupation with having or acquiring. And a very similar type, again, almost a variant of this, would be the preoccupation with having an imagined defect in appearance. What's that called? Exactly, body dysmorphic disorder. Now, body dysmorphic disorder, per the APA in 2013, DSM-5 was moved out from the somatic disorders, otherwise known as the somatoform disorders, into the anxiety spectrum chapter, specifically the obsessive compulsive and related disorder chapter of the anxiety spectrum. So that one was, but its close companion, illness anxiety disorder, wasn't for some reason. I have no idea how the APA justified that. For learning purposes, in your mind, do that. Kick it out. Put it in the anxiety spectrum. Obsessive compulsive and related disorders, traumatic and stress-related disorders, PTSD and related disorders, and then anxiety disorders proper are your 3 chapters. Oldboy, anything else? So on a scale of 1 to 10, 0 to 10, 10 being the most disturbing, what number for you guys? 9?
Yeah.
9? Anybody less than a 9?
It's Saturday.
7, 8?
Yes, more cheap.
7? 7, 8, 9? Anybody else? 6, I love it. Nerves of steel. No comment.
I think what tipped me over the edge was like definitely the ending, like him like cutting off his tongue. I'm like, that's awful. And him pressing the button, I'm like, that's even worse. And then the suicide in the elevator, I'm like, this literally cannot get you. Like, this is so wicked.
Right, so Unbreakable at 12:30, otherwise, have a good lunch, and we'll see you back here for Night's Watch.